Hello, my name is Bernard Sarmiento, and along with fellow authors Dr. Joane Titus, Dr. Sesha Kanakamedala, and Dr. Roger Crouse, I would like to talk to you today about a very interesting case of predominantly sensory Guillain-Barre syndrome. First, Guillain-Barre syndrome, or GBS, is an acute autoimmune polyradicular neuropathy usually occurring weeks after a gastrointestinal or respiratory infection. In GBS, cross-reactive autoantibodies form and begin to target host epitopes on peripheral nerve membranes, such as myelin antigens. This attack leads to an immune-mediated demyelination and axonal degeneration of all types of nerve fibers, motor, sensory, and autonomic fibers. Attack on the motor fibers leads to the characteristic symmetric and ascending flaccid paralysis seen in GBS. Attack on the autonomic nerve fibers leads to arrhythmias, ileus, and the feared respiratory compromise seen in GBS. Importantly, what we wanted to focus today on this clinical vignette is that Guillain-Barre's demyelination of sensory nerve fibers can lead to severe and debilitating pain. In fact, it is reported to be a common manifestation affecting 55 to 89% of patients. However, some patients can face an enormous battle with the amount of pain they are in. Our case is a 52-year-old man who presented to the emergency department for 3 days of worsening and progressively ascending bilateral leg weakness, 3 weeks after being diagnosed with a flu-like illness by his PCP. Physical exam was remarkable for hypo and areflexia in his biceps, triceps, Achilles, and patellar reflexes, interestingly with sparing of his brachioradialis reflex. Significantly, the patient also had lost most of his sensation in his lower extremities and was visibly anxious due to the cyclical attacks of pain. Objectively, the lumbar puncture showed an albuminocytologic dissociation with an elevated protein of 167 milligrams per deciliter with no white blood cells, which is highly suggestive of GBS in combination with his clinical presentation. What we wanted to note in this case is how much pain this patient was in for most of his 2-week hospitalization course. He described it like he was burning alive every night, with especially worsening neuropathic pain in his legs that ascended eventually to his lower back, shoulders, and arms. The pain was also associated with the onset of his plasmapheresis sessions and was compounded by his significant level of anxiety due to the pain. What we wanted to show was that we managed to significantly relieve his pain only after an exhaustive search, trying many of the first, second, and third line pain management options based on the literature of GBS-related pain. Although drugs such as carbamazepine, pregabalin, duloxetine, and many other choices did not provide any pain relief, and although we found that after titrating gabapentin to 900 milligrams 3 times daily provided minimal pain relief, the combination of a cocktail of hydromorphone 0.5 milligrams and lorazepam 1 milligram taken together in combination every 4 hours and also timed prior to the onset of his plasmapheresis sessions significantly relieved this patient's neuropathic pain. Our case was atypical because many of the agents used were simply ineffective for his pain, which is a critical part of providing supportive care in patients suffering from GBS. Although 75% of patients with GBS require opioids during their management, opioids alone do not provide significant pain relief in this patient, and hydromorphone needed to be combined with lorazepam along with the standard gabapentin 3 times daily to provide significant relief. Managing severe, predominantly neuropathic pain, such as in this case, may seem like a daunting task, but with an individualized, patient-centered approach where all available options in the right situation are made available to the patient and can produce a suitable outcome as seen in this case. We hope this vignette will aid clinicians when managing neuropathic pain in any presentation, GBS or otherwise. Thank you so much for your time.